So these are the contents of the presentation. I'm going to first talk about a little bit about how we got to start with the non-invasive PGT-A. And a few words about the post-test counseling, how we interpret the results and so forth. And then a bit about the results we have. And for the rest of the talk, I will be talking about false positives and why we get them and how we maybe could be better to identify which of those positives are false and which are not. And by false positives, I will mean that the result is not representing the developing embryo. So the result is what it is, but is it the result of the embryo? So we started with to think about niPGT-A around 2016 when there was lots of reports of the possibility of testing using the spent culture medium DNA. And one reason was because there were a few patients that had expressed concern about the biopsy. And not very many, but still there were a few over 40 years of age with clear indications that just denied, don't do anything to our embryos, just transfer them. And we did some studies, mainly with qPCR after that, and we had very promising results, we thought, so we decided that we need to go ahead with this. And another reason is that this can be implemented in labs that cannot afford to invest in lasers or biopsy training. So we have two small clinics in Finland that clearly belongs to that category. So hopefully they will introduce it later on. And looking at into the future, it would be very straightforward to do other testing. I mean, the embryos are sending other signals, microRNAs for sure, and so forth. So if those would be of value for testing the viability of the embryo and the implantation potential, it would be very easy to have one sample, many tests. And looking further into future, this would be compatible with microfluidic embryo culture methods, which, well, they are years ahead. But of this, it will not happen next year, probably. But someday it will happen, and by that time things will be look much better for not only niPGT-A. So we started validation in 2021, and we had very good success with Bioarray, both with day 5 and day 6 embryos. We had amplification success, clinically conclusive results, and over 90%. And at the same time, we thought, well, let's try Embrace at the same time, exactly the same washing procedure. And yes, they work with day 6 as for conclusive results, but the concordance rate was only 70. And we did a few of day 5, and those were worse. So we thought that in our hands, at least, Bioarray's system works much better. So we started in May sending samples to Bioarray. So this is more of a duplication of the slide Kirsi had. So, but in the beginning we thought a little different, but because we were, recommending PGT-A or niPGT-A, we were thinking that if we have 10% and 10% no result rate, then that might change things a little bit. If they have only one embryo and you don't get a result from that, well, great. But then we found out that the no amplification rate is very low, and so right now it really doesn't make any difference, expecting some special cases, as Kirsi pointed out earlier on. So how to tell the patients what to transfer. Of course, if you get a no alteration embryo, which we would call euploid, then there's no problem. We start with those. But we have aneuploid PGT-A findings, so we need to put those in order as well. And we first of all, we avoid all that have any of the risk chromosomes 13, 16, 18, and 21. So it's a no-no. And then we look at the aneuploid probability that is given in the Bioarray test report, and which we think looks quite valid. So we pretty much agree with that. So it's a good thing to look at. And then another thing we look at is, do they have aneuploid chromosomes other than those that we consider low risk aneuploids, which is 1, 3, 4, 5, 10, 12, and 19. So if you have 2, 14, 22 or so, not so good. So then also we look at which chromosomes have aneuploid arrays that are overrepresented in the niPGT-A data compared to the PGT-A data. I will talk more about that later, and much more. And in some cases, for instance, if you have an XXY or XYY or so, then we wouldn't transfer without genetic consultation first. Okay, so then what do we tell the embryos? I tried to make a slide with all the answers, but it was totally impossible, because there are so many factors that are involved. But let's just say that if you have many euploid embryos, then of course you transfer them first. The only exception would be that if you have many euploid embryos and high maternal age, and the first embryos do not implant, and you have one left, then we might say, you have only one left. So why not try another cycle to get a little bit more? But that depends on what kind of other embryos they have, of course. And on the other end, if you only have embryos that have the 25 to 40% aneuploid probability, then we recommend another cycle, because although you do get pregnancies from those, they are, well, not so high as in Western Romania, at least. But that may be because our patients are older in general. So, but in the end, you have to look at this and think about what the patient can afford and what the patient thinks about it. So it's really, it's a case-by-case situation. So, a few words about the results. We didn't have as good day 5 embryo results as we did in the validation for some reason. And after a while, we just skipped. We can't do this because every time you get a no answer, no result, it really pisses us off. And the patients don't like it either, especially if there are very few embryos. But for day 6 results, then again, we got much better results than we expected. So we are around 99.5% and of amplification success. That's better even than with the biopsies. And we detect maternal contamination in 3.4% of the cases. And we get inconclusive results, half of them due to maternal contamination and half for other reasons. And in some cases, you think that you could maybe transfer those anyway. But we're pretty happy with these results because pretty much the same as you get with biopsies. As for FET outcomes, we don't have enough transfer to to really say that this is as good or better or worse than biopsies. Also, we have lots of patients that are over 40 years old and they may have other problems, but that's true also for the biopsy PGT-A. But it looks like it's about the same that with biopsy. And when we have aneuploid niPGT-A findings, we do get pregnancy rates, but not as high as in Western Romania. But again, that's probably because the average age of patients is about 40, and most of the patients we have are over 40 years old. So that may have something to do with it. But still, we certainly transfer those, but we do not, at least for now, we don't transfer easily embryos that have less than the 25%. We have transferred, I think, 2 and no pregnancies, but we wouldn't throw them away, of course, but we will save them for last. And if we look at the aneuploid rates, first of all, this is there a pointer in this? Yeah. Look at these, not these, because these are pretty small numbers, and here between 30, 37, even less, and here even less. But these are big, large groups that we could look at. Well, we could see that there's more aneuploid results in niPGT-A. And part of that is due to the fact that there are much more segmental aneuploids in the embryos. Well, there are some in PGT-A, and even in PGT-A, some of those are probably artifacts, but definitely on the niPGT-A side. So if we split this into whole chromosome only and segmental only, we can see that yes, both are actually overrepresented. Of course, much will be explained by these segmentals, and the differences are not that big, but there are still differences. So, why do we get these false positives? I think that's the big question, because we get false positives. How can we know which ones are? What to do with this? Well, I'll speculate on this, and if you have better explanation, please tell me, but I think that the main reason is mosaicism in the embryo. Actually, about half of the embryos, or even up to 82% of all embryos, are mosaic, but we only see 5% of them in the trophectoderm sample, and that's because the sample is so small. So the mosaicism is more likely to be picked up when you looked at the whole embryo. But then, why would these false positive aneuploids appear in niPGT-A as full aneuploids rather than what you expect from mosaic embryos, partial gains or losses? Well, first, it's possible that DNA is released more readily in the medium if you have a poor quality cell or an abnormal cell. There's some controversy about this, but I think this is actually true in many cases. Then, and maybe more importantly, there are mitotic errors that cause missegregation, so 1 or 2 chromosomes or even more are just getting lost during the mitosis. They end up in the fragments and are released into the medium, and maybe they are even more intact. We don't know. The intact DNA molecules, which will amplify more readily. And well, in that case, if you get a few more chromosomes there, you would rather see gains than losses, right? And that's actually, well, here are some examples, like here's Chromosome 1, well, that's 3 copies, but 2, 3, and 4, 4 copies. And here, 4.5 copies. This is the normal 3. So you get, and you get even higher. You get something like 5 or 6 sometimes. How is that possible? Well, maybe because of this. Well, how about the results then? Well, there are more gains in chaotic and PGT results. In standard PGT, there are about 59% gains and 41% losses in chaotic embryos. But in NIPGT, over 80% are chaotic. So that would speak, well, that would fit well into the hypothesis, but of course reasons could be others. There are actually, the same is true also in complex and in single aneuploids, but less so. It's much clearer in this group. Well, then again, how do we identify these? Which results are false and which are not? Well, let's start with looking at the PGT-A data, the biopsy data. So here we have, these are data for embryos that have up to 4 full chromosome aneuploidies. I am leaving the chaotic ones out because there's something strange going on with this, and we still have to analyze that. But you can see that we can split this into 2 groups. All of these small chromosomes have higher frequencies than the large chromosomes. So it's kind of nice split here, somewhere in the middle. So let's use that and see. I could show the data for niPGT-A, but I'll just say that if we look at the large chromosomes, there are on average twice overrepresented in the niPGT-A data. Some chromosomes, I think it's chromosome 5, is 4 times more common in the niPGT-A data. So looking at the niPGT-A, PGT-A aneuploid frequency ratio, you could maybe learn something. Because if you have a true ratio of 2, that would mean that 50% of the cases are false, so they are unrepresentative of the embryo. Statistically, that should be the case. And with 4, it would be 75%. So maybe we could use this in the future, but we still need more data to get better, more accurate data of this. So we can say for sure that chromosome 5 is 4.08. It's probably somewhere around 3.5 and 5, but we need better data for that. And an example of this is we already had this data when we decided to transfer this embryo. So it's monosomy 5, trisomy 7, and trisomy 12, and also a little bit of segmental gain in 4q, but that's, we didn't really, well, we thought, well, probably artifact. Anyways, these have an average niPGT-A, PGT-A aneuploid frequency ratio of 2.65. So we were not very surprised that this became pregnant and is now ongoing at week 26. So another thing that could be used is looking at time-lapse data, and there's lots of things we can look at, but here's one example. Well, if you have a small chromosome aneuploid, it doesn't seem to affect the embryo growth rate much at all, or very little, depending on the chromosome, and we don't have enough data of that, but it looks so. But if you look at those large chromosomes, that you can see that yes, if you have a single large chromosome aneuploid and the embryo grows fast, like say faster than 70 hours, then the likelihood should be quite high that alone from this data, it would be Euploid. And if you add that with the ratio data, maybe you would have even better understanding. Maybe your aneuploid ratio, Euploid probability would be somewhere around 75, maybe. Hopefully, we can get that far. So we also will need other markers, and we need also experiments and which we hopefully will be able to do within 1 year or two to get a better idea of how we can pick up the false positives from the correct positives ones. We can use time-lapse data, embryo morphology a little bit, biochemical and metabolic markers, and there are many others that we can think of. So, in conclusion, non-invasive PGT-A is well accepted by patients, 90% taking it. That alone tells us that we are doing something right. It doesn't have to be as good as PGT-A, but lots of those patients would not want any PGT-A at all, which is not in their best interest. So that alone is really important. And the results are very encouraging, but we need still some tools to better pick up which embryos we should transfer of those that get aneuploid findings. So I will thank Bioarray for this arranging this meeting. We can already see that it was a magnificent idea, and I'm actually looking forward to the next one. And I would extend my thanks not only to the embryology group that Kirsi presented, but all our team at OVUMIA Tampere, because everyone has been very supportive of this marketing, and everybody very positive about this. And finally, I thank you for your attention.